Hi, our group is consisted of myself, Mira, and Nina, and our group's change proposal project will highlight the issue of nurse to patient ratios in the medical surgical unit. So what is the problem? Across the country, nurses, now more than ever, are being asked to care for more patients. Unfortunately for nurses, there is not much that can be done, as most healthcare facilities have the ability to set their own staffing ratios. Currently, there are 14 states that have passed some form of nursing staffing laws. These states include California, Connecticut, Illinois, Nevada, New Jersey, New York, Ohio, Oregon, Massachusetts, Minnesota, Rhode Island, Texas, Vermont, and Washington. However, in 13 of those states, the law only requires a general plan be in place to help manage the workload, as opposed to actually mandating set ratios. California is a lone exception, which has a ratio of 5 patients to 1 nurse on the medical surgical unit. So why need reduced ratios? Many studies have shown that when a nurse is forced to care for too many patients at once, patients are at a higher risk of preventable medical errors, avoidable complications, falls and injuries, pressure sores, increased length of stay, readmission, and death. According to the National Nurses United organization, for each additional medical surgical patient above the recommended ratio of 4 to 1, the likelihood of patient death within 30 days increases by 7%. The National Nurses United organization also reports that anywhere from 250,000 to 400,000 people die annually from preventable errors in their medical treatment, with high patient staff ratios being one of the leading causes. Another study in 2006 showed that if hospitals decrease patient to staff ratios to match the best staffed hospitals in the country, that 5,000 in-hospital patient deaths and 60,000 adverse patient outcomes could be avoided. Now, when looking at the impact of high patient to staff ratios and hospital readmission, a study reported that with each 1 patient increase, the readmission to a medical surgical unit within 15 to 30 days would increase by 11% per patient. It is evident that patient to nursing ratios greatly impact hospital readmission. The development of pressure injuries are another complication that increase in likelihood when patient to nursing staff ratios are higher than recommended. According to a research study, when the daily hours of patient care increased, the incidence of hospital-acquired pressure ulcers decreased. Here, we see a similar connection with the number of nursing assignments and the development of medical complications such as hospital-acquired pressure ulcers. When looking at patient to staff ratios and the incidence of patient falls, it has also been noted that they are more likely to occur when nurses have too many patient assignments. According to a study performed by Staggs and Dunton, the lowest staff units had a fall rate that was 19% higher than that of median staff units and a 23% higher rate than that of the highest staff units. Now, not only does high patient to staff ratios lead to worse patient outcomes, but it also has a negative impact on the nurse. It has been reported that high patient to nurse ratios are strongly associated with emotional exhaustion, job dissatisfaction, fatigue, and burnout. Burnout is a severe type of fatigue that has a wide range of symptoms, which include irritability, headaches, insomnia, back pain, weight gain, depression, and high blood pressure. According to a study, each additional patient a nurse has over the recommended ratio of 4 to 1 carries a 23% risk of increased burnout and a 15% decrease in job satisfaction. Eventually, all of these factors are too much to withstand, and thus we see an increase in nurses quitting, which significantly puts a strain on the nursing pool. Currently, 62% of hospitals across the country are reporting a nursing vacancy rate higher than 7.5%. Clearly, we can see that high patient to nursing staff ratios have many negative implications and need to be addressed.
We propose to improve the medical surgical work environment by establishing a new patient to nurse ratio in med-surg units at 4 patients to 1 nurse. Med-Surg nursing is the single largest nursing specialty in the US, with 58% of nurses nationwide working in medical and surgical hospitals. Med-Surg nurses tend to have a broad skill set and are considered jacks of all trades. They address a variety of disorders and illness presentations daily, and they also attend to the overflow patients from other units. The Med-Surg field is considered the backbone of nursing and was for a long time a stepping stone for the newly graduated nurses on the way to their coveted specialty. The Med-Surg experience gave the nurses a broad and solid base of nursing skills that prepared them for more specialized tasks. Historically, before medical profession became specialized to the present extent, nursing in general was medical surgical, and so it became a tradition to consider it as a kind of womb of all other specialties in nursing. From the broad base of Med-Surg nursing, the professionals ventured out into treating narrow groups of diseases, such as cardiac or oncology, or they focused on certain populations, for example, pediatrics. In nursing education today, the introduction to nursing begins with Med-Surg concepts and practices and progresses to other specialty areas of human health. While this approach seems perfectly logical, a closer look reveals that, unfortunately, this perception of Med-Surg nursing being older, primary, and broad devalued it, as if it is somehow easier than other types of nursing. And today, the Med-Surg nurses work at higher patient-to-nurse ratios, even though they work with very sick adults in varying states of acuity. We find the situation unfair and dangerous, and we propose to change it to achieve equity for the medical surgical nurses. Today in California, each Med-Surg nurse works with 5 patients, while pediatrics, antepartum, postpartum, ER, and telemetry units have a 4-to-1 ratio. Several other specialties have even more favorable ratios for the nurses. In step-down units, it's 3-to-1, and in ICU, 2-to-1. If we compare the Med-Surg workload with pediatrics, for example, we find that while the pediatric nurses attend to only 4 patients, they also typically get help from the patient parents and have to dispense far fewer medications than the Med-Surg nurses, who work with older, sicker clients with often complicated conditions requiring numerous medications. This creates a fertile ground for fatigue, professional burnout, med errors, lower quality care, and feeling unappreciated. Med-Surg nursing is often considered the least desirable among nursing sectors. That is unfair, and the situation calls for change. We think that the easiest way to remedy this problem is by lowering the patient-to-nurse ratio from 5-to-1 to 4-to-1. We argue that today, as the world population is growing larger, older, and sicker, the medical surgical nursing can no longer be considered the baseline of care and has become a specialty of nursing that deals with intense, complex, multifaceted health issues that exist at the cross-section of age, disease, new technology, and globalization with its unique vulnerability to pandemics.
When it comes to timeframes, AB 394, which provided for California's current patient ratio, took 8 months from being read the first time to being approved by the governor in 1999. Bills must pass through 3 votes to become a law, and the time for bills to pass through those votes is highly variable, so it is hard to pinpoint how long change will take. Some resources we have are Patrick O'Donnell, who is a state assembly member, and Lena A. Gonzalez, who is a senator of California. State assembly members and senators are the only people who can introduce a bill to pass through those 3 votes. Another resource we have is the National Nurses United organization. They are the largest organization of registered nurses in the US, and they've written publications that support safe nursing ratios. If we got their support, their collective voice has the weight and resources to help develop a bill. Some benefits, as Thomas has mentioned, of changing patient-staff ratios are improved patient outcomes, hospital savings, lower nurse burnout, and better nurse retention. Challenges we might face are, as of September 2021, it is estimated that there is a shortage of 40,567 full-time RNs in the US, and that gap is projected to persist until 2026. Hospitals may find it hard to hire more nurses necessary to support our proposed ratios. Another challenge is that hospitals that face financial uncertainty have often sought to reduce nurse staffing as a way to increase profitability. We need to convince them with statistics that poor staffing ultimately costs more in the long run, all the while leading to poor staff retainment and patient outcomes. And we know that ultimately, promoting health is the whole goal of healthcare. And that would conclude our presentation. Thank you.